and I just want to do an official welcome to everyone for the first substantive call of our trauma-informed advocacy work group. This is going to be a first in a series of calls that will be presented in 2-hour blocks to our trauma-informed advocacy work group. The mission of that work group is to ensure that guardian ad litem advocacy is aligned with the latest research on child development and trauma. So this call will be the first in a series as we begin assembling credible, relevant information to make recommendations in that regard. All of these calls will be recorded and then placed on the Guardian Ad Litem program website at www.gal.fl.gov. Today, we're very fortunate to have Dr. Kimberly Mcgrath from Citrus Health, who has extensive experience in child welfare systems. And I am going to go ahead and let Dr. Mcgrath do a little introduction herself, and I will turn over the presentation at this time. Thank you, Dr. Mcgrath.
Thank you. Good afternoon, everyone. I hope we have no issues you have no issues hearing me. If you do, please speak up or type a response. At Citrus Health Network, we're a federally qualified health center, and we have been operating foster care, therapeutic foster care programs for over 20 years. I have been working in the child welfare system, working with children who have histories of abuse and neglect for over 19 years. Currently, we operate specialized therapeutic foster homes, residential group care homes, and in-home services for youth in the child welfare system. One of the programs that we operate is called the CHANCE program, and those homes are specialized therapeutic foster homes for youth who have been commercially sexually exploited, as well as a clinical wraparound, intensive clinical wraparound in-home team for youth who have been commercially sexually exploited that can live anywhere in Miami-Dade County. They can live with foster parents in shelters or group homes, and our team provides services. So all that being said, I do have extensive experience working with youth who have experienced trauma. Today, the topic of our talk today is the impact of trauma on children. And we're going to cover a few objectives. First, it's putting trauma into perspective. So we'll be covering basically what is trauma. When people say that a youth has experienced trauma, what are they talking about? What is it like to be a youth who is suffering from an experience of trauma? How does that traumatic experience change a youth or a person? And then why is it important? Why is it important as the guardian ad litem, as a service provider or a clinician or a foster parent to understand trauma and the impact of trauma? How can that understanding of trauma improve services that we provide across the spectrum of services and down to the more individual level? What can I do? How can I help a youth who has experienced trauma? So to start with, I think it's important that we talk about the fact that there are a number of different types of traumatic events. When we're talking about youth and child welfare, we know that a significant number of youth have experienced neglect, as well as physical abuse and sexual abuse or sexual assault. So physical abuse and sexual abuse and neglect are one of the primary reasons that youth come into care. So we know that that happens to be in their history. But trauma also takes other types. There can be a natural disaster that a youth has experienced. In Florida, unfortunately, we're very familiar with youth who have experienced significant hurricanes. We also have exposure to violence. There's traumatic grief and loss. We have youth who have experienced serious accidents. As adults, we have the military combat, and typically our youth have not experienced terror attacks, but they may have. But one type of traumatic event that we know that the youth that are residing in foster homes is that they have at least experienced the traumatic impact of separation and removal from the home. And that in itself, removal from the home and placement into foster care, is associated with a number of losses and is considered a trauma in itself. So when you're working with the youth, it's important to understand what their traumatic experiences have been, what traumas have impacted them, what is their history, what does that look like. A diagnosis of trauma, if you're looking at, a definition of trauma, in the past, trauma really focused on an event or a series of events of circumstances that were directly experienced by an individual. And that experience was physically or emotionally harmful or life-threatening. Now, with the addition in DSM-5, it is noted that vicarious exposure of trauma is significant as well, that a youth does not actually have to experience the event themselves, that it can be witnessing a traumatic event or hearing repeatedly about a traumatic event that occurred to a close family member or a close friend, or the threatened injury, death, or impact of a family member or a close friend can also be a very traumatic event for a youth. So that DSM-5 expanding the definition of trauma to include vicarious trauma has been so significant for our youth and child welfare, who we know are exposed to significant community violence. They're often exposed to violence in the home, and sometimes when folks are working with those youth, the impact of that trauma is minimized, and we know, and now it's nice to see that DSM-5 has now included vicarious exposure to trauma. So when we're talking about trauma, it's important that we keep in mind what we call the 3 E's of trauma, and it's a good way to kind of conceptualize trauma. The first is the actual event, the actual or extreme threat of physical or psychological harm. And so what was the actual event that youth experienced? And then secondly, how is that individual experiencing the event? And that we'll talk a little bit, but how that youth experiences the event is influenced by a number of different factors, including development, which is significant, and I know and I understand that you're going to have a whole second training on trauma and over the course of the lifespan, but development, cultural influences, so the experiencing of that trauma is significant. And then effects. What are the effects? What are the immediate effects of having that exposure to that trauma? What is the long-term effects? And how long do we anticipate that the youth will experience these effects? So when you're talking about trauma, it's important to keep in mind those 3 E's, the event, the experience, and the effects of the traumatic experience. When we're talking about trauma, what exactly are we talking about? We know that 7.7 million Americans aged 18 or older have been diagnosed with PTSD, and that 51% of the general population have experienced trauma in childhood. 51%, so that's 1 out of every 2 people that you meet in the streets have had some significant trauma in their childhood. And that 98% of the people served by behavioral health experts have experienced trauma over the course of their lifespan. Many of you are probably familiar with the Adverse Childhood Experiences scale. Adverse childhood experiences emerged from an effort of researchers who really wanted to look at these traumatic experiences in childhood and see, do they correlate with health problems in adulthood? From those researchers, they developed a 10-item scale where they looked at 10 different types of trauma, from emotional abuse, physical abuse, sexual abuse, down to parental divorce, separation or abandonment, and parental incarceration. And they presented this scale to a number of different individuals. On the screen in front of you, I just put a few, I didn't put all 10, but just to give you an idea of the questions on the Adverse Childhood Experiences questionnaire, so you can see the way it's worded. So for example, question number 1 says, when you were growing up during the first 18 years of life, did a parent or other adult in the household often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? And you answer the question yes or no, and you give yourself a score of 1 if the answer is yes. And you go through for all of the questions. And I'll give you a moment so that you can read just a few of those questions. So those are the first 5 questions, and you can Google Adverse Childhood Experiences Scale and get all 10. I do encourage everyone, take the Adverse Childhood Experiences Scale and see what your ACE score is. The original ACE study included over 17,000 participants aged 19 to 90 years old, and what they found is that 64% of the participants experienced at least one adverse childhood experience, so one exposure to trauma. And of those 64%, 69% reported 2 or more incidents of childhood trauma. What these results showed is a connection between childhood trauma exposure and high-risk behaviors and chronic illnesses. Looking more in depth at this study, what it showed is that 1 in 6 men experienced emotional trauma, and that 80% of people in psychiatric hospitals experience physical or sexual abuse. 80%, that is such a significantly high number. 66% of people in substance abuse treatment reported childhood abuse or neglect, and 90% of women with alcoholism have experienced trauma. So this population, the population of folks that we see in the courtroom as guardian litem, as for parents of the children that we serve, and we know that these folks have alcoholism in their history, then we also want to consider, do they have a history of trauma? Do we need to be administering and talking to them about what their own history of trauma is? What we also found is that 64% of adult suicide attempts and 80% of the child-adolescent suicide attempts are attributable to adverse childhood experiences. So basically, in general, what we're looking at when we look at the Adverse Childhood Experiences Scale is that we know that once we see an ACE score of 4, so an individual who has experienced 4 or more adverse childhood experiences in their childhood, that we see increased risk of suicide, that we see that increased risk of engaging in high-risk behaviors, that we see the depressive disorders, alcoholism and drug use, and oftentimes those physical health problems. Some of those, the chronic illnesses that we know are linked to the adverse childhood experiences is heart disease, cancer, and early death. So we are actually seeing consequences on physical health related to adverse childhood experiences. When we talk about an individual who has experienced those multiple traumas, we know that multiple victimizations, then we say that that individual has been polyvictimized, or that they are experiencing complex trauma. And it's multiple victimizations of different types, such as a victimization of sexual abuse and a victimization of physical abuse and exposure to family violence. The reason that it's important to mention that is that folks who have experienced polyvictimization, that polyvictimization is much more powerful than even multiple events of a single type of trauma. So we know that repeated trauma of one type is significant and impactful, but what research is showing is that trauma, repeated incidents of different types of trauma is even more impactful on an individual. And that complex trauma or that polyvictimization is so significant. One population that we are focused at Citrus Health Network is commercially sexually exploited youth. And we started our CHANCE program back in 2013, and there was very little information out there related to sexually exploited youth. What did this population look like? What have their childhood experiences been? Where should we begin treatment? And we immediately contracted with the University of South Florida to do research on our programs, looking at both youth outcomes as well as program outcomes. We have significantly changed our program based on the data that we've received from this research design. And the reason that we've done that is we have been so surprised by many of the findings, the early demographic findings of the population. One of the findings that has been most significant that really has shaped the course of treatment for these particular youth is that the children who have been commercially sexually abused had significant incidences of early childhood trauma prior to becoming involved in commercial sexual exploitation. I mentioned that in the ACE study, the finding was that if you've had 4 or more significant adverse childhood experiences, that you're at risk for so many factors, the high-risk behavior, the physical health problems. In our study, we found that youth who have been commercially sexually exploited have experienced 6 or more adverse childhood experiences, so considerably higher than the 4 needed that we consider that critical threshold. In fact, 11% of our youth in our program have experienced all 10 significant adverse childhood experiences. And our study is not the only study that has found this. DJJ conducted an adverse childhood experiences study where they looked at youth in detention who have been flagged or indicated to be sexually exploited compared to other non-sexually exploited youth. And they also found that youth victims of trafficking violations had the highest rates of adverse childhood experiences above the general population of youth and above offending youth. Having this polyvictimization makes these youth particularly vulnerable to re-victimization throughout adulthood, and it is so important to make sure that we're addressing the trauma that our commercially sexually exploited youth are experiencing. In our particular study, we did find that over 80% of our youth who are currently being commercially sexually exploited had that prior childhood history of sexual abuse. This TEDx video, I think, really summarizes adverse childhood experiences very well. I'm hoping that the sound quality, we had a little issue in our practice, but I think we resolved it. So hopefully this will play, and it's a good summary of adverse childhood experiences.
So silence gives consent. And today what I'm hoping is we can break from silence, even when it's uncomfortable, because I think we want to do important things. What I want you to reflect on is if you or someone you know has experienced one of the following 10 events prior to the age of being 18, emotional abuse, physical abuse, sexual abuse, feeling unloved or unwanted by your family, being afraid your basic needs might not get met, a divorce or separation of your caregivers, witnessing domestic violence in your home, someone with a substance abuse issue or a mental health issue in your home, someone in your home incarcerated, all prior to the age of 18. I've just defined adverse childhood experiences, ACEs, otherwise known as childhood emotional trauma. And it's a health risk that increases social problems in our community, raises our risk for disease, and can even shorten our lifespan. The Center of Disease Control names it as the prime determinant of health. And yet, unlike texting while driving or smoking cigarettes when we're young, for most of us, it's still an unknown epidemic. And yet, 70% of the general population has had at least one of those events happen. That's 1,050 people in this room and about 7 people in your row. 1 out of 6 of us has had 4 or more of those events happen. And that's 240 people in this room and probably 1 or 2 people in your row. And yet, we're not talking about it. Even though when it goes above a 4, some pretty hard statistics come about. At a 4, we're over 1,500% more likely to attempt suicide, over 550% more likely to become an alcoholic, COPD, liver disease, asthma. At a 6, we're more likely to die 20 years younger than our counterpart, at age 60 instead of age 80. And so we need to embrace what this silent costs us. I want to introduce you to Henry. At 18 months old, Henry moves into your community, and neighbors go to knock on his door. but they hear loud screaming and noise inside, and they look at each other and say, you know, we do crime and watch and checking building maintenance, but I don't know if we're in for this. And so they walk away. At 2.5 years old, he goes to daycare, and they notice Mom has a bruise on her eye, and Henry's kind of aggressive in class. And they go, Director, should we do something about this? No, she says. We're in charge of good quality child care, not this. And so things go on. At 5 years old, he's put upstairs in his room, and he hears a loud crash downstairs, and he comes downstairs, and Mommy's bleeding on the kitchen floor, and Dad's standing above her. 4 big police officers burst down the door. They grab Dad and put him in the police car, grab Mom, put her in the ambulance, grab Henry, and lock him in the car. A woman comes and taps on his window. She has his things in a garbage bag and says, come on, let's go. He drives to a new neighborhood where he knows no one, falls asleep in a bed, not in his pajamas, crying himself to sleep. He wakes up in the morning going to a new school that he doesn't know, and the teacher yells at him because he has a hard time following the rules. And he says, wow, that sounds like Dad, and I don't even know where Dad is. And next, he moves from school to school, and his foster care parents get angry at him, and they start yelling at him and begins wetting his bed at night until a new social worker comes and says, come on, put your things back in the garbage bag. We got to move again. And he wonders how many places he's going to have to live, where his parents are, and if he'll see them again. His behavioral health file gets this thick, and so does his school file, until one day they tell him his parents aren't his parents anymore, termination of parental rights. And so now he's up for adoption, but nobody really wants him. And so he's in his 10th foster care placement at 11 years old, and foster dad and foster mom are fighting, and he thinks, I'm never going to watch someone put their hands on someone else again. And he steps in and he takes a swing, and the next thing he knows, he's in handcuffs in juvenile detention. Now, that's a tough story to hear. And what I want you to think about is 12 systems and 50-plus people crossed Henry and his family's life. And no one thought it was their job to connect with them about that hard story. And that doesn't make sense to me because, right, we're caring people. All of us are. And so I wonder, maybe it's because we were taught it's not our role. It's not our place. Or maybe from a more hidden part of ourselves, we think that's Henry. That's his family. We can't change stuff like that. That's them and this is us. What I want you to hear today is this is not an us-them conversation. This is an all-of-us conversation. And if we choose to keep our story of silence, this epidemic's going to grow. And that feels uncomfortable, right? And if I'm doing this right, you feel uncomfortable because when we get uncomfortable, we grow, and that's a good thing. And you might be saying, Allison, what do you want me to do about this? I mean, I don't know how to break this silence. I might not have the right letters behind my name. I might not have any letters behind my name. I mean, violence and abuse, that seems like pretty big stuff. And what I would say to you is this. 70% of why anyone changes a negative health behavior is because of the person who connects with them and inspires them to change that. Relationship is the evidence-based practice, connection. And you don't need the right letters or any letters to do that. So I want to tell you about Kat. Kat had 8 of those 10 things happen before she was 19 years old. She went from residential placement about between the ages of 13 and 19, about 8 to 10. And she was the kid that broke windows and tore down doors. Sometimes she was held down in restraints and injected with Thorazine. She tells the story of a nurse who one time said, you know what, Kat, at your age, not your shoe size. I own this place. You got to come through me to get out of here. And that's who Kat would have thought she was until she met Howard, a mental health tech who had no letters behind his name, but he understood connection, and he was willing to go past his role. And he said, you know what, Kat, I get we need to connect, and he had to find her motivation. So he took her to the gym and said, you know what, I want you to exercise, and if you give me 1 solid hour of really good exercise, I'll let you go back to the unit and tear everything up. And she said, hell yeah, right? The joke was, though, that when she walked out of that gym, she was crawling, and she couldn't lift a chair to throw, okay? And that was Howard's plan, although she didn't know that. And so Howard looked at her, and he said, she began telling these chapters of her story. And he said, you know what, Kat, I see something in you. You're going to do something important in your life. Well, Kat had never heard that before, and so she liked that. So she did what Howard didn't plan and got locked up a lot to see him. That wasn't the intention. And so she came there one day, and he said, Kat, you coming here to see me? And she said, yeah. And he said, here's my schedule. Meet me in the lobby. Right? We don't need to do that. So she did. That's how she got through high school. The thing is that hard stuff doesn't stop happening at 18. Kat went away to college. She was raped. She went through a serious suicide attempt, and she came back to the adult psychiatric institution, the same place where she was as a kid. Howard found out she was being admitted, and at 2 in the morning, he came to her admission and said, "Kat, please don't give up before you know what you can become. I'm going to hold hope right here till you're strong enough to grab it. Right here." That was the last time Kat attempted suicide, the last time she was locked in a residential placement, and the first job she ever had was a psych tech on a unit like Howard's because she promised to pay that connection forward. Now, we're sitting here with 2 stories, and that's the intention. For centuries, stories have taught us how to make meaning. Dr. Brené Brown teaches us that we are hardwired for connection, and that one of our deepest fears is disconnection, a fear of not belonging. And so we're sitting with a story of disconnection and connection. That gives us a choice. We can think about Henry before he threw that punch, the 12 systems that crossed his path, the 50-plus people that chose not to connect, and we can think maybe if somebody had connected earlier, that story could have been different. And we can think about Kat, because Kat might not be who you think, because Kat's story is my story. My nickname throughout school was Alley Cat. And if Howard had not made a decision to connect with a kid like me, I truly believe I would have been in an institution, dead, or probably in jail. And so we're not powerful enough to know who's had trauma and who hasn't. We're not powerful enough to know who makes it and who doesn't. But we're powerful enough to do 2 things. 1, teach someone else about childhood trauma as a health issue. And 2, take that risk of connection. I think about if somebody came up to me and said, "You know, Allison, I saw this awesome doctor on Friday talk about childhood trauma, and they told me that I should tell someone about it. And I'm wondering if you would listen." I think I would have listened, and I think it would have made a difference. Mavis Leno once said, "If you want to make a difference in the world, the next time you see someone being cruel to another human being, take it personal, because it is." And what I would add to that powerful statement is the next time someone gives you the honor of walking their trauma, their pain story in front of you, answer that call with connection. Because you see, ordinary acts of courage can change this. It's not going to be the monumental events. Thank you so much for listening to my story.
I think one of the most powerful things that Dr. Jackson says in this video is that connection is the evidence-based practice. And if that's one thing that we can get across in this training today, is that connections are so important. And as guardian ad litem, what is that one thing I can do? It's you can make that connection. You can be that connection for that child who has experienced trauma to either share their trauma or help them start to navigate through those waters and heal from their trauma. We're going to start moving into how trauma impacts youth, from brain development to emotional responses to thinking and learning. At this point, though, does anyone have any questions about what we have covered so far? Okay. So, in regards
Dr.
to
McGrath,
trauma,
I'm sorry to interrupt. There was one question in our question box that asked, how did the study, and I assume this is the ACEs study, isolate any genetic factors in mental illness rather than assume it was the childhood trauma?
They didn't. They weren't able to do that. That was beyond the scope of that initial study. It was just highly correlated with the significant incidence of adverse childhood experiences. So there may have been a genetic impact for some and maybe not for others, but that wasn't looked at. That was beyond the scope of the study.
Thank you. That was the only question.
Okay. So let's now talk a little bit about brain development and trauma. We have made in the last 12 years significant advances in the study of neurobiology and neuropsychology. And one of the most, I think, significant findings has been that there is now an understanding and a recognition that there is actual changes in the physical structure of the brain youth have experienced childhood trauma. And there's also changes to the chemical composition of the brain. And we'll talk a little bit without going, I'm not going to bore anyone and go into great detail, but we'll talk in a few minutes about what some of those actual physical changes are. But what's important to keep in mind is that because of these changes in the structure of the brain and in the chemical composition of the brain, that one of the main things that we see in our youth is what we call a heightened fight-or-flight response. And we'll also, again, talk about that in a little bit more detail. But we also see in youth what we call body dysregulation. And we see youth that over-respond or under-respond to sensory stimuli. So we'll have youth, for example, that are very hypersensitive to sounds, smells, touch, or light. And those youth are responding and hypersensitive to that stimuli because of the trauma they've experienced, which has resulted in changes in that brain structure. So, for example, we operate a residential facility, and oftentimes we'll have a youth who absolutely cannot sleep if there is any type of light in the hallway, in the bathroom. They're extremely sensitive to that light. Or we have youth that's just extremely sensitive to sound. They have to have a quiet space. They have to have a quiet room if things start to get a little hectic on the unit. And it's very important that the staff that work with those youth have a very solid understanding that these youth aren't trying to be challenging. They're not trying to break rules or bend rules, that these youth are very hypersensitive, and that those things, although they may seem minor to other youth, that because of the trauma they've experienced, because of the changes in the composition of their brain, they're very sensitive to these things. We also see youth who are unaware of pain or any type of internal physical sensations. So we'll have these youth who will have a high fever, will be diagnosed with strep throat, and then will say that they don't feel pain. And those youth are being very honest. They're being very straightforward, that unfortunately they're under responding to sensory stimuli. And again, it has to do with those changes in the physical structure of the brain or the chemical composition of the brain. One of the concerns with that is that those particular youth can injure themselves without feeling pain, or we have the opposite. We have youth that somaticize, and they talk about a lot of chronic pain because that is their body's way of responding to sensory stimuli is with pain. We know that brain development, it remains ongoing throughout adolescence and early adulthood, and that prefrontal cortex, right, that the part of the brain that affects decision making and planning, that it's not fully formed until the age of 25. We often talk about those youth at the age of 18 and aging out of foster care, that they're trying to be independent and live independently and make these adult decisions, when the part of the brain that actually affects decision-making and planning isn't even fully developed yet. And then when we have youth who have experienced significant trauma, we know that some of that brain development has been delayed or compromised. So these decisions, that decision-making process is incredibly challenging. And then we also know, and again, you're going to go through a whole developmental trauma piece, but we know that there are also critical ages of brain development, children aged 3 to 6 and then 13 to 16, that are what we call a critical development phase, and that trauma during that age range is also very important in terms of brain development. 3 areas of the brain that I think are fairly easy to understand and important when we're talking about trauma. One is the amygdala, and the amygdala in the brain helps us manage fear and emotion. And what we see is that pervasive trauma exposure, that there's the amygdala, there's reduced volume. What that leads to or can lead to is an inability to calm down, meltdowns, and very strong reactions in our youth. And that's directly related to a reduction in amygdala volume. The corpus callosum is that connection. We call it the bridge of the brain, and it connects the left and the right hemisphere of the brain. And this is really our integration area. So it integrates the motor, the sensory, and cognitive performance of an individual. And with trauma, we do see, especially when folks have been diagnosed with PTSD, we see a reduction in the size of this bridge. And what happens with that reduction in that size of the bridge is that brain activity, that connectivity between the left and right hemisphere is more compromised. In the hippocampus, which is responsible for learning, emotion, and consolidating long-term memories, research has demonstrated that there is a decrease in the size of the hippocampus proportional to the PTSD symptoms that somebody is experiencing, and this can result in forgetfulness or learning problems. So in the past, it had been hypothesized that trauma would change brain composition and brain structure, and now with advances in MRIs and PET technology, we are actually able to confirm that yes, that trauma actually impacts the structure of the brain. So that fight, flight, or freeze response that I mentioned, that is our internal alarm system. And we know that through evolution that was a pretty powerful tool and helped keep us alive. That when there was impending danger, the body had to prepare to do one of three things. It had to fight, it had to flee, or we had to freeze. That is actually an adaptive alarm system for an individual. But what we see in youth who have experienced trauma, especially polyvictimization, is that internal alarm system is overly sensitive. It's always activated. So our individuals, our youth, have a heightened sense of fight, flight, or freeze. So small or what would appear to be insignificant stimuli to somebody else can cause our youth to react and react very strongly and very quickly. So there have been situations where we've heard, oh, that youth, they fight over the smallest thing. They respond so intensely and so strongly for no reason. There is a reason. The reason is that youth has exhibited significant trauma, and they are in an enhanced and heightened internal alarm system state. And because of that, we have to approach that youth differently. We have to understand that their natural response to fight, flight, or freeze is heightened, and we have to approach them differently. Now, that being said, what's very important to keep in mind is that every child reacts to trauma differently. There are two children will not react to the same trauma in the same way. What we do know is kind of what we say could be typical or customary responses to traumatic events, and that's what we are going to talk about, keeping in mind individual differences because they are so significant for our youth. And we know that reaction to trauma is dependent upon so many things. Developmental level is obviously one that is very significant. So for example, if a child at the age of 2 has experienced a trauma, the way that child is going to respond, the signs and the symptoms of a traumatic response that you're going to look for are going to be very different than if that child is 16 years old when they're experiencing trauma. So for example, we would look more at, has that child all of a sudden regressed in their bedwetting every day? Have they stopped eating? Are they having difficulty sleeping? Are they crying, irritable, and fussy? We would look for those types of symptoms as opposed to that 16-year-old who we would still look at sleep, we would look at appetite, but we would also look at, are they exhibiting low frustration tolerance? Are they exhibiting behavioral problems? So what we're looking at is slightly different based on developmental level. We also know that reaction depends on their premorbid functioning. How were they functioning before the traumatic event? What are their previous life experiences? What is their support system to be able to get them through this traumatic event? Level of exposure to the trauma is also significant. What was the intensity and duration of the trauma? Were there multiple traumas? And also important for our particular youth is what was the parental reaction to trauma. We know studies have shown that parental reaction to disclosure of sexual abuse is so significantly correlated with positive outcomes for individuals, for children. Parents who have strong and supportive reactions to disclosures of sexual abuse, that those children fare significantly better than children whose parents were rejecting when they received that disclosure of sexual abuse. We also know that following that trauma, like what were the changes in a child's living situation? If there was a significant change in that living situation, that reaction to that trauma can be fairly significant. But overall, what we do know is that kids are pretty amazing, and that the majority of children are incredibly resilient. I know that in my time of working with youth in the child welfare system, I often say that these kids are just unbelievably resilient, and I couldn't have worked through half of what many of our children have suffered, experienced, and overcome, and they're thriving. So with regard to an emotional response to trauma, when you're working with youth, you want to look whether they're 2 or they're 18. You want to look and see what is their emotional response, because what we know is that youth who have experienced trauma often have extreme difficulty identifying, expressing, and managing emotions. If youth cannot name an emotion, then they can't express or cope with that emotion. Naming and identifying emotions is one of the first things that they have to learn to do. And they just lack the language for their feeling states. Those same youth, oftentimes they will internalize a stress reaction, which means that we'll see depression, we'll see low frustration tolerance, we'll see sadness, withdrawal. However, another youth may externalize that stress reaction, and we'll see them acting out with anger, with different types of impulsive acting out type behaviors, aggression. So it could be internalizing, it could be externalizing, but how they're handling that stress reaction is significant. Overall, we know that emotional responses of youth who have experienced trauma can be unpredictable or explosive, and that our youth can become easily overwhelmed and frustrated, and that is that heightened fight or flight. So if you see a child either withdrawing and starting to isolate, or you see that youth starting to engage in an aggressive way, that it's probably because that youth is becoming overwhelmed or easily frustrated. We often see too that individuals will say, there was no trigger. This child was fine. I was interacting with them. There was no problem. And then with no trigger, I started to see that they were becoming unpredictable or they were becoming explosive. And our response back is typically, there usually is a trigger. You just may not have known what that trigger was. Because many times children are reacting to reminders of traumatic events, that something in their environment, something that you said, somehow your interaction triggered a memory of that traumatic event, which caused that type of reaction. So it wasn't out of the blue, it wasn't out of nowhere that child is reacting that way. It's because that child was triggered. And having that conversation with that child, what happened? What happened when you reacted in this way? What were you experiencing? What were you thinking? What were you feeling? For many children, in the beginning, they won't be able to even identify their feeling state, never mind what the trigger is. But over time, when they learn the words, they will start to be able to identify not only what triggered them, but what that correlated feeling was. What we also know is that trauma significantly impacts interpersonal relationships. And that traumas are often interpersonal, especially for youth in child welfare. Many of the offenders of either the violence towards the child or violence in the family were individuals that they trusted, that they had a significant, strong interpersonal relationship with. So because of that, interpersonal relationships can be trauma reminders. And they can trigger intense emotional responses. Children learn over time that they have to be vigilant, that they have to be guarded in their interactions with others. And they can also learn to misperceive situations as stressful or dangerous, given their history, given the experiences that they've experienced. So while that is a protective response to be guarded, it can also be problematic in situations. And it can be problematic for our youth and child welfare when they are being placed in situations where we want them to attach, we want them to engage, we want them to start establishing strong interpersonal relationships with individuals that have been deemed appropriate. And we have to work with those children to be able to identify where that intense emotional response is coming from and how we can work on that response so that they can be receptive to building new, positive, and healthy interpersonal relationships. One of the best things that we can do with working with folks who are working with children who have been traumatized is help them understand it's not personal. Their reaction to your interpersonal relationship with them or your attempt to establish an interpersonal relationship with them is not personal. It's not directed towards you. It is based on their history, based on the trauma that they have experienced. That is why you are seeing the intense reaction. It's nothing that you're doing. But we're going to talk at the end about things that you can do to help these youth develop those interpersonal relationships. And then with regard to behavior, what most folks talk about when they see or experience a youth who has experienced a history of trauma is we hear a lot about the behavior. And we really need to look at that underlying emotion and know that those underlying emotions are contributing to these behaviors. So yes, we can see intense reactions and we can see that lack of impulse control. We need to look at why. Why are they reacting that way? One of the things that is very common in youth who have a significant history of trauma is that they can react very defensively or aggressively if they're in response to perceived blame. So that if they believe that they are being blamed for something or the finger is being pointed towards them for something that they didn't do, or even if it's something that maybe they do accept responsibility for, that defensive reaction, that aggressive reaction is expected. Unfortunately, what we also see with youth who have a history of trauma is that they often seem unfocused or detached or distant. We are doing a great deal of work with our teachers in the school system to help them start to identify youth who potentially have that history of trauma. We have teachers that will say they just disengage in class. They start staring out the window. They're not paying attention. They're bored. And oftentimes it's actually not that the child is bored or not that they're not invested in learning. It's that their history of trauma is getting in the way of learning. They're so focused on the trauma reminders. They're having flashbacks. They're so immersed in thoughts of the past related to trauma that they seem unfocused. They seem detached or distant or out of touch. And it seems as though they're just bored and disengaged when in fact they're responding to their history of trauma. And how do we ground those children? How do we get those children back to get them focused so that they can be successful in a classroom environment or in an environment that requires them to be focused and present? One of the ways that we do that is in treatment, and we know that without treatment, that youth with a history of trauma are more likely to engage in all of those high-risk behaviors, that heightened fight or flight, and that escape and avoidance is very high. So I started to mention, the thinking in the classroom setting. And we talked about how the brain structure is impacted and that it can impact that long-term memory. And obviously, one of the ways that that long-term memory plays a role is that thinking and learning. And we see that our youth who have significant histories of trauma can have problems thinking clearly, reasoning and problem solving, that prefrontal cortex. They can struggle with sustaining attention or be distracted, especially if they happen to have trauma reminders for some reason in that classroom setting or in that classroom environment. And that oftentimes activities that require organization and planning and foresight is incredibly challenging. There is a quote here on the screen that I think is so significant. It's that when children grow up under conditions of constant threat, all their internal resources go towards survival. When their bodies and minds have learned to adapt to a chronic stress response mode, they may have trouble thinking a problem through calmly and considering multiple alternatives. All their internal resources go towards survival. So if you could think of it that way, that these youth were so busy surviving, their body is in such a heightened state of arousal that focusing, thinking clearly, problem solving, sustaining attention in the moment and being present can be incredibly challenging for these youth. Because we know that self-concept, that learning is challenging, we start to find that youth who have histories of trauma, they start to have negative interactions in the classroom setting. They start to withdraw from the classroom setting, and oftentimes they start to have such significant academic problems that it can lead to academic failure. Related to that academic failure is often that a loss of the future goals. What kids once thought or saw themselves as becoming in the future, what their future goals would be in the future, considerably change. They lose direction, they lose focus, and unfortunately, they start to limit themselves and believe that a child who may have wanted to go on to college, go on to post-secondary education, now their goal is that they just want to get through high school or maybe even just get the GED. And all related to that is also the fact that trauma impacts self-concept, that we see that there is shame, there's guilt, there's low self-esteem and a poor self-image that's often highly correlated with youth who have experienced significant trauma. When we're talking about youth who are experiencing this poor self-image and then they also have this loss of future goals, they start to believe that the world isn't safe. It's just a place where they can't trust and that they're powerless to evoke change, and they have trouble feeling hopeful. And that's where those connections are so important. Those connections are what bring kids back and ground youth and help them reestablish what their self-identity is, what their self-image should be, and how their future goals can look, and what they need to do to achieve those future goals that are more in line with their pre-morbid level of functioning, what they believe they could do and could be successful at prior to experiencing trauma. We already know that the consequences for physical health, we mentioned this in the adverse childhood experience, that chronic illnesses such as heart disease, cancer, and early death are related to that childhood traumatic exposure. Any questions before we continue?
Dr. McGrath, this is Deborah Lacombe again. On one of the slides, you had listed certain behaviors that children will engage in after suffering trauma. And I was just wondering whether all of those behaviors are equally correlated with the type of trauma, or, you know, for example, you had dissociation, engaging in high-risk behavior, intense reaction. Is there any correlation between the types of trauma that children experience and the way that they act out, or is a child equally likely to experience any of those things regardless of their type of trauma?
The way a child responds to trauma is more individualized. It's not necessarily related to the type of trauma. It's more related to those factors that I mentioned before, their pre-morbid functioning, their social supports, what is their support system, are they getting intervention and services, how did they perceive the trauma? So it's more the interpersonal factors and the resiliency of the individual that impacts what you'll see, the manifestation of the trauma, than the actual type of trauma itself. Now, we do know that intensity and duration of trauma does impact the manifestation of the symptoms. So the longer the duration, the more intense the trauma, that we will see more significant symptoms. But again, whether we see internalizing behaviors or externalizing behaviors, those are interpersonal factors of the child that contribute to that response, not necessarily function of the trauma itself. There's been twin studies that are really interesting. You can Google twin studies in trauma, and you'll see that two twins can be exposed who are, genetically very similar, exposed to the same type of trauma, and we believe raised, right, in the same environment, exposed to the same social supports, and their reaction to that trauma can be incredibly different. And again, what is that factor? What factor is it that causes those two twins to have such a different response to that same event? Does that answer your question?
Yes, thank you. I appreciate that. And if there's anyone else on the work group that has a question for Dr. Mcgrath, you can ask it now, or you can put it in the chat box and we can get it later.
Okay. So we're going to move on a little bit. So there's a great understanding now that systems of care need to be trauma-informed, and that folks who are working with youth who have experienced and families who have experienced trauma should be utilizing a trauma-informed approach. And you'll hear a lot, folks will say, well, I'm trauma-informed, my approach, my agency is trauma-informed. And what exactly does that mean? What does it mean when we say we're utilizing a trauma-informed approach? And in a nutshell, what it means is that that agency or that individual realizes the widespread impact of trauma. That trauma is impactful, and it causes significant biological changes in individuals that can have lifelong and lasting effects. What it also means is that that agency or that individual recognizes the signs and symptoms of trauma in clients and families and people that are involved in the system. So we're identifying that trauma is impactful, and we're recognizing the signs and symptoms, and then we're responding. And we're responding by integrating knowledge about trauma into our policies, our procedures, our practices, the way we approach people, so that we are not re-traumatizing individuals. And that when you're able to do that, when you're able to realize, recognize, respond, and avoid re-traumatization, then you're actually working in a fully trauma-informed system of care. So there are really 6 principles to make sure that you're following as a professional, as an agency of the trauma-informed approach. The first, hit the screen. The first is safety. As an individual working with a youth with trauma, you have to ensure that that individual feels safe working with you, whether it's environmentally safe, so that the places that you're meeting that individual is safe, they feel safe, they're perceived to be safe, and that also that they can trust you, that they believe that what they tell you, what you say to that child is relevant and it's sincere, and there's going to be follow-through, that there's transparency, that individual can believe what you're saying. Peer support is also important. That's in our 6 principles of trauma-informed care, that as often as possible, when we can introduce our families and our children to others who have experienced similar issues and they can get that support from others who have lived that life experience, that is impactful. That there is collaboration with that individual, with that child, that that child feels as though they have a voice, they have choice, that they're part of the process of whatever the process is, whether it's a treatment process, whether it's a court process, that they feel as though they have a voice and choice and that they're important in this process. And that when you're working with this individual, that you're keeping in mind the gender issues or the cultural and historical issues that this individual is facing. When we are talking about safety, and as a guardian ad litem, one of the things that you might want to think about is safety planning with that individual, and talking through how can they feel physically safer, how can they feel psychologically safer working with you. Are there any threats in their environment that you need to consider when you're working with that individual? And walking that child or that family through safety planning is so important. And also in terms of emotional management, working with that client so that they can be less reactive, they can develop trust, and develop adaptive coping strategies. For some folks, that emotional management piece can be challenging, and that's where we often say, bring in the therapist, meet with the therapist, and they can work with you, with your client, to help your client identify those coping skills, to help you learn skills and techniques that you can use when you're working with these children or with these families, that you can bring into your meetings, and teach these individuals how to manage their emotions. But most importantly, that we talked about this in the beginning, but the loss, to recognize that many clients have suffered enormous loss throughout their lives, and that our kids have suffered enormous losses. Not just loss of family and separation from family, but often separation from siblings, from schools, from teachers, from sports teams. Everything in their environment that they were surrounded by, they often lose when they come into child welfare. And acknowledging that enormous loss is so significant. And then helping these youth define and move towards those positive future goals is so important. So how do you do that, right? That sounds like it's easier said than done. Well, one of the first things that you can do is to establish that importance of safety, establish that sense of safety with that child. Establish boundaries, establish routines, be very clear what they can expect from you. These are the expectations that you should have of me. These are the things that I can and cannot do. Down to if you're going to have an interruption in the time that you can see the individual, or you're going to be interrupted when you're talking to the individual, let them know that, so that when they are with you, they feel that they are safe. And establishing trust is the key. Working with youth who have been traumatized, you have to follow through on what you said you would do. And if you can't do something, you need to preface that in the beginning by saying, I'm going to try to do X, Y, and Z. I don't know if I'll be successful, but that's what I'm going to try to do for you. Allow choices whenever possible, and just listen and show that you're understanding of their needs and that you're supportive of their needs. What are some things that you should do? Remember, as Dr. Jackson said, connection is the evidence-based practice. Relationships are so important. What you want to avoid is interactions with these youth that are harsh or interpersonal, disrespectful, demanding, or judgmental. Sounds like common sense, right? We know that those are the things that we should be doing and we should be avoiding. But to be trauma-informed, our interactions express patience. We're calm, we are accepting, even if we don't like the choices that that child is making or the decisions that that child is making, we're understanding that that's part of their healing process, and we have to be accepting, even though we may be redirecting their choices. Frequent use of words like please and thank you and that respectful interaction goes so far in establishing trust with these individuals. When we're talking about policies and procedures and establishing rules, whether you're working with them in foster homes or with biological families, you just want to work on a few things. And one is making sure that there's not so many hoops that you have to go through to get a child's needs met, or that individuals have to go through. It can be incredibly frustrating and really damaging to the relationship process if they're asking for things that seem reasonable, but because of these barriers, these policies and procedures that are in place, we can't meet their needs. Also taking into consideration language and cultural barriers, and trying whenever possible to make sure that clients are appropriately matched with the appropriate individuals that can communicate effectively with them. So we want to make sure that when we're working with our youth that we avoid asking questions that are conveying that there's something wrong with them. So I've been in interactions with youth where I've heard individuals say, you know, why do you react like that? What is wrong with you? That is the absolute worst thing that could be said to a child, because we're conveying that there's something wrong with them. Instead of asking that individual, why, it sounds like you have a pretty intense reaction to that. What happened? You know, there's a very different meaning and intent and tone in working with a child, asking what's wrong with you as opposed to why did that happen. And understand and recognize that symptoms, behaviors, they're manifestations of coping with trauma. That is trauma. That is a manifestation of the trauma. That is the way the individual copes. And if we understand that and approach that child from that perspective, the way that we interact with them is going to be trauma informed and going to be more successful. So when we're working with youth, it's really important to understand that children who have experienced trauma often experience crisis as they're going through their healing process. And we know that some of the immediate causes of crisis is that they often feel overwhelmed, right? There's an overload of emotional stress. Before a child, for example, has to go into a courtroom, that can be an incredibly stressful time, and they're overwhelmed by emotional stress. It could be that they perceive a situation as being unfair or humiliating, or they feel like they don't have voice and choice and power in a situation, and that can cause a crisis. It could be that they're depressed, that they have a trauma trigger, whatever it might be, that could be an immediate cause of a crisis. What do we see in children after they're starting to experience at the initial stages? What do we start to see? We start to see signs of agitation. And it's really important for us as professionals to be able to intervene when we see that first sign of agitation. We do not want to wait until a child who has experienced trauma is in full-blown panic or full-blown emotional meltdown before we intervene. We need to intervene at that first sign of agitation, when that child has a raised voice, when that child starts speaking very, very quickly and rapidly, or when we start to see that their posture has changed, that they're balling their fists, that they're starting to get into an aggressive posture. When we start to see those first signs of agitation, that's where we need to respond and when we need to respond. So as a professional, how should you be responding to those children? The first thing that you need to consider is that your nonverbals are incredibly important. Your nonverbals are probably more important than your verbal response to that individual. If you can remain calm, stay centered, and stay self-assured, confident in interacting with that individual, it's going to go a long way. Make sure that you're maintaining eye contact, that you're not getting an angry and frustrated look on your face, that you remain relaxed in your posture, do not get into an aggressive stance, and that you are avoiding touching that client. What we see oftentimes in the trainings that we have provided is that one of the first responses as children start to get agitated, adults seem to want to calm them by touching them, putting their hand on their shoulder, putting a hand on their arm. And what we see with youth who have experienced trauma is that can be extremely agitating. It can be extremely triggering to children and can escalate a situation very quickly. So you want to avoid touching your client until you have gone through a process with that individual that you know that they find your touch calming. So unless you have processed, how do you want me to respond when you start to get agitated? Do you like when I touch your arm? Do you like when I touch your shoulder? Then please do not touch your clients because you can agitate them. So I mentioned that the tone of voice and the facial, the nonverbals is so important. What research has found is that your facial expression during a crisis is 55% more of what the youth looks at. So 55, more than half of what the youth is perceiving is your facial expression. 38% is your tone of voice. So it's not even your words, it's your tone of voice. 38% of what they're perceiving is your tone. Only 7% is the actual words that you're saying. So your facial expression and your tone of your voice is critical in times of crisis and de-escalating those situations. So those strategies that you're going to employ are so significant. So you're going to stay calm. You're going to keep your voice neutral. You're not going to be in an aggressive posture. And you're going to work at ensuring the safety and de-escalating that client. Again, what you actually say is often less important than how you say it, but you will work on diffusing the situation, whatever that situation might be. I want to talk just a little bit more about that verbal communication, because that calm and controlled tone of voice is so important. And it can be extremely challenging, especially if a child is starting to escalate and they're starting to raise their voice. It's almost natural as an adult is they start to raise their voice because they want to make sure that the child is hearing them, that the child is understanding the message that they're trying to convey. But that raised voice or a fast tone of voice, that just will increase excitement or anxiety in the client. So you have to really make that effort to keep that voice tone calm and make sure that the language that is being used is appropriate and respectful and conveying the appropriate message to the client. And then in verbal de-escalation, what you often want is just to listen. The child often just wants to be heard. They don't want you to give them a solution. They don't want you to give them an answer. They just want to be heard. So many times children convey this as they're escalating, they're verbally saying, "You're not listening to me. You're not hearing me." So sometimes the best thing that you can do is stay quiet and let the child know, "I hear you. I hear what you're saying to me." Or repeating just back very calmly to the child, "I understand. You're telling me that you're upset because of," simple sentence, nothing elaborate. "You're upset because the court date changed and we didn't tell you. I understand you're upset about that." That's it. Can't solve the situation. You can't come up with a solution for the child, but you're acknowledging for that particular child that you hear them and that you're listening and that you care. So when you're doing for listening skills, one of the most important things is attending, is making sure that you are maintaining that eye contact with that child and that you're there and that you're physically present. Nodding and just letting the child know, "I'm here, look at me, I'm engaged, we're in this together," is so significant. And again, what I mentioned before of just validating and understanding of their concerns and their feelings is important. Folks have in training said, well, if I'm validating what an individual is saying, does that mean that I'm conveying that I agree or that the actions that they're taking are appropriate? And the response back is no, that doesn't. When you're validating a child's feelings and their experiences, what it means is that you understand where they are, where they're coming from, and that you can empathize with their emotional state and how they're feeling at the moment. But it doesn't mean that you're in agreement or that you're endorsing a behavior or a statement. That those are two very different things. You can very much be present and validating for an individual and acknowledging that child without being in agreement with their behavior or their actions. Once a child starts to de-escalate, then you can start to offer solutions or options for the problem and start to problem solve with that individual. What we often see with folks, though, is they start problem solving in the middle of escalation. That's not the time. You don't want to start offering different alternatives and different solutions to a child who is verbally escalated, tantruming, yelling. They're not hearing you. All they need at that time is to be acknowledged and de-escalated. Later, after the child has started to calm down, is when you want to acknowledge their concerns and you want to start problem solving with them. A few things to keep in mind that we always mention in our trainings is that when you're engaging in de-escalation and when an individual starts to escalate, you do always want to kind of keep in mind safety. You want to make sure that you're in a safe place, that there's not individuals around you that would be put in an unsafe situation if your client escalates, and you want to make sure that your client is safe. Keeping in mind that having hard conversations with individuals that you know may be triggering, making sure that that conversation is in a place of safety is critical. A lot of folks like to take, for example, youth to parks to have tough conversations, and they kind of think in their head, well, it's a tranquil setting, it's a great place to have a conversation. Well, it may not be if you have a youth, for example, who has heightened fight-or-flight, who, when they're stressed, they want to run, if that park is near a highway or near a main road, and that child's response is fight or flight, then that situation may not be where you want to be when you're telling a child some stressful information. You might want a more enclosed environment, an environment where you have the opportunity to de-escalate and intervene. Another thing is that keeping in mind the audience reaction. If you have a client or a child that you're working with and you're concerned that that child may escalate, keeping in mind that an audience will often trigger and escalate feelings of anxiety and anger. So working on situations and settings where you can keep that child separate, where you can share information without an audience is so significant. And that's extremely challenging working with youth who are going to court, because there's often not a place in the court where you can work privately with an individual. There's a few communication barriers that we want to avoid. We can talk about them, but I see some things blinking at me here, so I'm not sure. Does anyone have any questions before we move on to the next step?
We do have some questions in the chat box going back probably to the beginning of this little segment. Lee or Marcia, I will give you a second to ask your question if you want, or I can read it if I don't hear you speak up in the next couple seconds.
Hi, it's Lee. So I had a thought after you asked last round for questions, and so I hesitated, and I thought, well, we'll just go ahead and put it in the chat box. But this is a question that refers to sort of in the beginning part of your presentation, Dr. Mcgrath, and I wondered about kids 0 to 3. So there was a slide that showed sort of the effects of trauma on brain development for kids and the importance of that, this particular stage from 3 to 6 and then 6 up. But I wondered about 0 to 3, and it has occurred to me, not to like point something out or challenge, but we work with, the National 0 to 3 organization, and we work with early childhood courts here in Florida, and so I just wanted to make sure that in your presentation that you at least had addressed that age group too, if you could, and just to say, how they fall in the scale.
Sure. Now, again, what was on the screen in terms of brain development were just what were considered critical stages. That does not mean that trauma impacts brain development across the lifespan. Those were just have been identified as extremely critical phases. Okay. But 0 to 3, absolutely, there is an impact of trauma, both on brain development and attachment, behavioral changes, behavioral responses. So absolutely. It does not minimize. It does not mean that there's no impact there at a 3 or 6 to 9. It's just that 3 to 6 has been identified as a critical stage. And I know in I tried to keep away so I'm not duplicating efforts of your next training, but sort of what you can expect to see in terms of a response or signs and symptoms, so to speak, of trauma for an individual who is 0 to 3 as opposed to 3 to 6 or 6 to 9, because I know that's coming in a future training. But obviously what you're looking for in a child from 0 to 3 can be different than a child who's 16 to 18. But we're looking at still some categories that are significant. Emotional response, sleep, appetite, attachment. You're still looking at all of those categories and looking for regression or changes or disruptions. Okay.
All right, great. I just wanted to hear you say that. I appreciate you saying that on the call today.
Oh, no,
Thank you.
Sorry. I will clarify in future slides what I mean by critical periods.
It's okay. Thank you so much.
Any other questions? Okay.
Dr. Mcgrath, if you don't mind, I'll read another one from the chat in case you'd care to respond to it. We had one of our members note that it's interesting that though we're learning more about children's reactions to trauma, as a provider system, that person feels we've become more punitive in our approach to children who exhibit fight, flight, or freeze behaviors. Foster parents, group homes, and hospitals are involving law enforcement far more than has been done historically, and they made the observation that few of the psychological evaluations emphasize the effects of trauma or reference best practices for approaches to treatment. So I just wanted to give you an opportunity to respond to that if you wanted to.
I think that foster parents who are struggling with the training that they received related to trauma are absolutely, yes, using law enforcement more frequently. And unfortunately, I think that's related to risk. They have been trained that there's a risk associated with fight or flight, right? That if children run, they could be harmed, they could get hurt, and they're trying to bring down risk involving law enforcement and, in fact, sometimes re-traumatizing children, because we now have children who are traumatized with that interaction. Sometimes not, and I'm not saying that involvement, I don't want to be quoted as saying that that law enforcement involvement with youth is always traumatizing, because that is not what I'm saying. But at times it can be traumatizing to a youth. But foster parents have to be trained. It's an unrealistic expectation that foster parents will know how to deal with the behavioral manifestations of trauma and intervene appropriately if we don't provide that training for them. And traditional PRI training has a component, that behavioral component and a trauma component, but there needs to be a significant trauma overlay when working with children who are in the child welfare system. And foster parents have to be taught techniques, direct techniques of how to intervene with children who have experienced histories of trauma. So I am in agreement that we see that. Until foster parents have the appropriate training, and then they know how to respond appropriately. They want to do what's in the best interest of the children, typically. They just sometimes lack those skills and that knowledge necessary to be able to do that intervention in an appropriate manner. And we unfortunately, we see that across the board. The piece about the psychological evaluation, it's true, and it's striking to me. We will see individuals who are being commercially sexually exploited, and they are referred for a psychological for someone who doesn't have the experience working with youth who are sexually exploited. And then when we review that psychological, it's focused on the behavior. And there you can tell that there was not enough time spent looking at the early childhood trauma, the trauma that existed prior to their sexual exploitation, and that there's no link between the behavioral manifestation, the behavior being a manifestation of that prior trauma. And again, it's a training issue. When we're referring folks for psychologicals or psychiatrics, we need to make sure that those folks are well versed, whether it's in child welfare or commercial sexual exploitation or early childhood development. Make sure that the appropriate experts you're referring to the appropriate experts. Unfortunate, and we do, everyone has a niche, and making sure that those individuals are being referred to those folks with that niche is significant, and it's important. Does anyone, whoever wrote that question, do they want to expand on that a little bit more before we go on? Okay. So one of the trainings that we do for our foster parents, speaking of foster parents, is actually the next slide that you have on your screen, and it's communication barriers to avoid. And we're not going to cover all of these, but we do train our foster parents that these 16 barriers are so important when you're working with children of trauma, that you are working to avoid them in your daily interactions. Everything from arguing with the child to overreacting to statements that that particular child may have made, to engaging in power struggles. We work often with our folks to please pick and choose your battles. Do not engage in power struggles over minor details. Let's save our battles for significant things that really need to be accomplished. And that youth with histories of trauma are very sensitive and responsive to these communication barriers. And the harder we work to make sure that we're avoiding them, the better our relationship and our trust with these individuals will be, and we'll get farther along in our treatment process with them. Eye contact. I mentioned this a few times, and I wanted to review it because I just wanted to bring up the cultural differences related to eye contact. When I say maintain appropriate eye contact, if you have an individual who you're finding absolutely refuses to make eye contact with you, and then you're processing their cultural background, it's important to make sure that you're not interpreting a lack of eye contact immediately as fear or a lack of interest on behalf of the child or any type of rejection from the child, when there could be cultural factors that are playing a role in the eye contact. Some youth will find that if you're keeping excessive eye contact, like you're constantly trying to maintain eye contact and they're avoiding your eyes, they can actually see that as challenging or threatening. So having a conversation with that individual about the eye contact is important. Oftentimes, what we see in our field is that adults are just assuming a lack of eye contact is a lack of respect, and that may not necessarily be the case, especially with abused children. We have worked with abused children who have told us, you know, I was told not to make eye contact with adults. I was told that I could not look adults in the eye. And so perceiving that as a lack of respect is completely inaccurate and will impact your relationship with that child. And the next step is also in terms of movement. I talked about keeping that relaxed posture, but also keeping in mind that children of trauma, they respond very quickly to sudden and sharp movements, and they can be easily startled. We talked about that heightened fight or flight. So if you're moving too quickly or you're making sudden moves, even if you're just reaching for a phone or trying to get some assistance for them quickly, getting a solution for them, they can perceive that as being very aggressive or attacking, or just it can be very intimidating and startling for them. So you really want to minimize your body movements. Again, we already talked about the touching and making sure that that physical contact is minimized, because that really can increase anxiety and agitation for the child. So in summary, when we're talking about de-escalation, with children who have experienced trauma, We want to make sure that we're present, that we're alert, but that we're calm and we're relaxed. We're attentively listening and we're responding and acknowledging that we hear the child and that we are responding appropriately to the questions that they may be posing or the situation that they're having. We will offer options and solutions for the client, but we're going to do that when it's appropriate. We're not going to do that in the middle of a full-blown escalation or emotional crisis. We're going to ask those questions. We're going to offer those solutions later. We're going to avoid those communication barriers that I just talked about. That is the quickest way to escalate a child, especially if we're doing any type of blaming or any type of power struggling in the middle of an escalating situation. You will continue to evolve into crisis as opposed to finding a solution. We did talk about positioning for safety or alerting others if need be when you're working with an individual who's starting to go into crisis. And that is the summary of trauma. We actually have some time for questions or conversation, so feel free to speak.
Do we have anyone from the trauma work group or staff that wanted to kick off any kind of questions for Dr. Mcgrath? I made a note of a couple, but anyone on the work group want to jump in? Okay, well, I'll kick us off, and hopefully we can have some discussion, since we do have some, we did set aside some time for that. I thought this was great. Well, first of all, thank you. I thought it was wonderful. I learned a ton, and I also find myself in the happy place of, feeling like I not only got an overview, but could take from your presentation a lot of practical advice on how to interact with and understand the children that are coming to guardian ad litem. I was going to ask you to get your opinion, big picture. My understanding is that we started with ACEs. I think it was related to weight loss 100 years, when they first started this. And I just wanted to sort of get your thoughts on how, starting from ACEs and starting that initial understanding of trauma, how that has changed and refined itself nationally over the last, probably decade or so, and then how you feel, how you see Florida applying the science in a big picture policy way, so that maybe we can take some lessons from that as an organization.
Sure. We definitely saw probably eight years ago, I think 8 to 10 years ago, where folks were starting to acknowledge that settings needed to be trauma-informed working with youth, especially courtroom settings, academic settings, and definitely, obviously, treatment settings needed to be trauma-informed. And then we started to see that folks' best practices related to trauma intervention in the treatment setting started to be required, which was so important for providers who are applying for grants or who are working with youth in the child welfare community, but there was no one really providing oversight in terms of what interventions were being used, what trauma-informed treatment protocols were being used, for example, with youth in child welfare. So then we started to see SAMHSA and others saying, okay, we now have this body of evidence that shows that trauma is impactful. In fact, even has, physiological and developmental factors and influence and changes over the course of the lifespan. So in terms of prevention programs and intervention programs, now we're starting to see Okay, research is showing what the best practice is in prevention. What is the best practice in intervention? And those practices need to be used with youth and child welfare. So we're seeing a streamlining of the process, which should, quote unquote, lead to more effective outcomes for our children, which is positive, and I think all of that is positive. Unfortunately, what we sometimes see is that folks are using the words trauma-informed and they're using the words best practice, but they don't exactly know what that means. So although programs will say they're trauma-informed, when you start to break that down, there needs to be more of an overlay, more of a training, more enhancements that are put in place. But I think the positive is it's being acknowledged that it's important. It's being acknowledged that there are interventions that are out there, prevention and intervention out there that has research that shows that it's effective. Now it's getting it across systems so that our school system is trauma-informed. Our folks that are working in our school system are trauma-informed. Folks that are working in our child welfare system are trauma-informed. All of those things are so important. I just saw a question pop up that says, are judges required to learn trauma-based training? And it's such an interesting question because the answer, from what I understand, is no. However, many judges are leaning towards an understanding that a trauma-informed courtroom is the most appropriate. And as in Miami-Dade County, for example, we are seeing that many of the courtrooms are working to being fully trauma-informed. And what does that mean? It means exactly what I said, that everyone in that courtroom recognizes that trauma is prevalent, understands the signs and symptoms of trauma, and knows how to respond appropriately to trauma. So that means that everyone in that courtroom, not just the judge, but the attorneys, the guardian ad litem, the court reporter, everyone has an understanding of what trauma-informed care is and that they're able to apply trauma-informed techniques and interventions with the families and the children that are coming before them. That is really judge-specific from what I'm seeing right now. I don't see like a standard across the board, this must happen in the judiciary. But there is an acknowledgement and an understanding of the importance and how effective trauma-informed courtrooms can actually be.
This is Alan Abramowitz. Great presentation, Dr. McGrath. Really appreciate it. I look forward to sharing this with all the other volunteers and staff and policymakers, by the way. I had a question regarding, you're doing the slide on communication barriers to avoid. And I know when it comes to talking to children, sometimes they feel manipulated. And I know when I heard attorneys talking about their representation, and some of them were saying, well, I don't have to represent something that is not good for them because I counsel them. And, I know I've talked to kids and I can always get them where I need them to get, like my own kids, on making a decision. But in the end, right after I leave, they know what they want. It's different from what I'm going to do, like if it's to get us to spend money on this toy or that toy, whatever it could be. And so I'm wondering, I didn't see manipulation on communication barriers to avoid, but I think it's something that happens with people interacting with children. And the second thing I want to say is clearly we need to have more training for volunteers. This is important stuff, and I think it's going to make us more valuable to children to have people listen to this, but even further. And the last thing I would want to comment on is children change their mind every day. I've been in situations where I've been the GAL on a child and they want something, even if it's like, I want to go to court no matter what. And I tell everyone, let the judge know, let everyone know. And the next day they say, I don't want to go to court. I do not want I'm not going to court. And then I'm going, oh God, I know the next day they're going to want to go to court. So I don't know if that's part of their situation with what's happening in their life at the moment, but in my working with them, they seem to change their minds a lot, and how you grapple with that as the GAL, especially when it comes to that part about saying their wishes. Just any comments on that?
Well, yeah, and I think developmentally we know it's appropriate that they'll be ambivalent and they will change their mind. But I think what you were really speaking to is transparency, and it's talking with the child and helping them understand that I hear your expressed wishes and I hear what you're saying. So let's kind of talk that through. What does that mean? You want to do X. What are the pros of that? What are the cons of that? Can I accurately, can I express what I think is in your best interest, and let me tell you what that would be? And being very honest and saying, I hear you, you want X, but these are the reasons why I can't recommend X for you. And some folks they don't want to have that transparent conversation because they think that it will interfere with their relationship, and they'd rather employ techniques or tactics that you use the word manipulative to get the individual, that child, to believe that they're changing their mind or that that's their mindset. When that manipulation, that lack of transparency, that's going to impact the relationship. Having that relationship with the child, I care about you and this is why I'm saying X, Y, and Z, but I do hear you, and being able to convey, this is what you want and this is why you want it, but we're going to have to agree to disagree on this, is so valuable, because kids will respect that. They might be angry at the moment, but they're able to come back and say, I do respect that you were honest with me, you were clear with me, you didn't lie to me. Transparency is so important. So there is that struggle. I know we talk about it all the time in trainings that we do with the court between expressed interest and best interest. And one of the things that we say is that in child welfare, there's folks who are designated to make decisions for the youth because we know that they don't have the ability, they're not cognitively able to foresee all the consequences, plan accordingly for the future, look at the big picture. Just developmentally, it's not appropriate. And there are people that have to do that for them or help lead them and guide them down that path so that they can see that overall big picture. So sometimes that's the role that we have to take, and just being very transparent in that and saying, this is why. The worst thing that you can do for your relationship with that child is tell that child in private, okay, I'll represent it. I'll tell the judge, you want to do X, that's what I'm going to tell the judge. And you don't go tell the judge that. You tell the judge something different. That will get back to that child, and then that lack of transparency, that trust is destroyed. So I definitely agree with you with training. We are constantly training at Citrus. We're training the gals, we're training the courts, we're doing as much training as possible, and learning from each other, because oftentimes when we're doing these trainings, I'm learning as much from our guardian ad litem program as I am sharing information on how do we walk that fine line between that best interest and expressed interest.
Hi, Dr. McGrath. This is Lori Blaze. I had a couple things, if you wouldn't mind touching on them. I think you touched on one thing just a little bit, and that was the ACE, the screening, and then assessments, and then trauma-informed treatment. Could you talk a little bit about that process? Because I think it's important for us to kind of understand what the ACE screening does, and then assessments that are specific to trauma in terms of how that's impacting the child, and then what kind of intervention that child might need. So not all kids that have been exposed to trauma would need some kind of trauma treatment. So could you talk a little bit about how all that stuff works and how somebody might sort of figure out if a child needs a specific trauma treatment intervention, and how to individualize it for that kid? And then also if you could talk a little bit about intergenerational trauma, and kind of considering the fact that a lot of parents have also experienced trauma and kind of what that looks like and how that impacts kids.
Sure. Actually, if I could take your question from that point and work backwards, I think with coming from the perspective of guardian ad litem or youth and the child welfare, we are actually at our agency a proponent that all family members of a case in the child welfare system, that the child and the family have a trauma screening because of that intergenerational component, that we know that many times the parents of the youth that we're working with have their own significant histories of trauma that can impact their progress on case plans or service plans, and that they have treatment needs that need to be met before they could even really effectively work case plans for their child. So, for example, they may have their own history of sexual abuse, and you can't expect them to complete non-offending parenting classes for their own child who was a victim of sexual abuse until they completed their own treatment for their sexual abuse. So we actually are a proponent that a screen, and a screen's a simple, easy little measure, be used for all family members that are involved in the child welfare system. Now, in terms of a comprehensive trauma assessment, what would typically trigger a referral for an assessment is that there has been some change, significant change in the child's level of functioning pre and post trauma. So if you have a parent that's presented that has said, you know, my child was a straight A student and had no behavioral problems and was sleeping well, and you're not seeing that post-trauma, that could trigger a referral for a trauma assessment. You would want to look and see is that child experiencing a trauma reaction? Are they experiencing flashbacks? Are they re-experiencing the trauma? Are triggers of the trauma causing significant distress? You want to look and see that for that particular child. If the answer to that trauma assessment that's administered for the child is yes, then there are best practices that are out there for the specific traumas. For example, with our agency, with the children who have been commercially sexually exploited, we use TFCBT, trauma-focused cognitive behavioral therapy. We obviously use that intervention for children who are 12 and older, who are verbal. So you really have to look at the individual characteristics of the child. For younger children, for example, under the age of 5, my program, we do not specialize in trauma treatment for under the age of 5, and we make sure that we refer to a play therapist who specializes in trauma and play therapy dealing with trauma. So it really depends the child, again, the characteristics of the child, the age, are they verbal, are they nonverbal, what's their cognitive functioning, will determine what intervention is best for that particular child, starting with that comprehensive trauma assessment. So whoever completes that trauma assessment should be able to guide you and say, this is the appropriate trauma intervention for this child. Or no, this child doesn't need any type of intervention or services related to trauma. Did that answer the question? Did I lose you?
I think we're here. I don't know if Lori has gotten muted through her phone or her microphone, so I will just say thank you for that comprehensive answer. And we do have a few more. I noticed I kind of lost track between questions and chat. Out of our chat box, someone asked how you would suggest overcoming barriers to communication where the child is triggered by the conversation you're having, but the guardian ad litem needs to have the discussion to effectively and diligently represent them. And then they gave an example saying of a child who's been reunified with his parent, but now does not want to have any discussion about how they feel about the reunification of their safety.
Right. Well, I think there's two things that we need to look at. Is it the conversation that's triggering the child, or is it the fact that maybe that trust in that relationship hasn't been established yet? Because I think I've seen situations where trust has definitely been established with the guardian or with the therapist, and certain conversations are still triggering. But we've also seen situations where that trust is not there yet, and that's an extremely challenging conversation. So in that situation where the trust maybe hasn't been established yet, I would say bring in your resources. Bring in somebody who that child does trust. Hopefully there is an identified trusting person in that child's life. Whether that's a foster parent, whether it's a therapist, bring them in to support that conversation. Because you might find that that child will be more willing to share with you with the presence of that trusting individual. If it's a situation where you believe that no, the trust is established, we have a trusting relationship, it's this particular topic is triggering, then you have to do it gradually and over time. I would suggest working with a therapist that works with the child, that's teaching that child coping skills, so that in your conversation, as your conversation is progressing, you can be reminding that child to utilize that coping skill, taking breaks, applying a coping technique, going back to the conversation. If you could bring the therapist in, great. I know some conversations have to be private, just gal-child. But then working with that therapist, what do I do? What are his signs of agitation, and how do I respond? So that you can get through that conversation. Oftentimes, too, use other means besides speaking directly. We'll have that child write a letter, have that child record an audio, have them write a little journal, do something else where they can express their wishes without having to look you in the face and directly speak. As long as it's coming from the child, it should be appropriate. We find a lot of our kids will rap or sing and record it so that we can share it with others, and they're expressing themselves through their singing, through their recording, through their rapping, and getting whatever information the gal needs is expressed in that audio recording.
That's a great example. Thank you, Dr. McGrath. I again am just always astonished at how many little adjustments that a guardian ad litem could make in order to accommodate such a big problem, you know, where, as you're saying, maybe not having the eye-to-eye verbalize this very traumatic feeling for you could still be accomplished through another mechanism. And there's another question in chat that's similar, I think, in nature, although not exactly about talking between the guardian ad litem and the child. One of our members asked how you balance the child's right to be present in court under the rules of juvenile procedure and the possible triggering effect that the court proceeding can have on the child.
Yeah, that is extremely challenging. What we have tried to do, especially when young children are going to be present, is we have met with as many folks on the team, so opposing counsel, the child's counsel, the guardian, the therapist, and have really walked through what is acceptable for the child to hear and what's not, and when should we ask for that child to be removed from the courtroom. What would be damaging for that child to hear. And in those situations, we've had the most success where the children have felt supported. They felt though they had a voice in the process, but then also they weren't negatively impacted. There have been other situations where children have been in the court, and it's been extremely damaging for the child to hear, whether it's the complaints against the parent or the details of the case. It's too overwhelming, and it has really set that child back in treatment. So the best suggestion is meet as a team and determine when the child's going to be present, what are acceptable topics, and what need to be discussed when the child's not present. There is no simple solution to that, but everyone, a trauma-informed courtroom would acknowledge that the child's presence is impactful, and monitor and be careful of the information that's being conveyed in front of that child. And sometimes, if I could just say, It's not the information that sometimes is so damaging, it's the way the information is presented. Our words are so powerful. So, for example, we may have a teen that needs to have a drug test. Hearing an attorney say, I believe that child's dirty, they need a screen, can be really damaging, as opposed to hearing an attorney say, I'm concerned about that child's health and their well-being, and I'd like to make sure that they're not utilizing drugs that can negatively impact their health, so can we have a screening? The wording is very different and will send a different message to the child. Or the mom that goes into court and says, I'm worried about that child, that they're going to get hurt in the street, they're going to die on the street, they need to be locked up, as opposed to the mom that says, I'm concerned for their safety. I don't think they're safe in the community. I'm afraid that they're going to be harmed. Very different messages. So oftentimes it's not what's conveyed, it's how it's conveyed. And if everyone in that courtroom can work together, the information can get expressed just in a different way.
That, again, that's a very, I think, powerful takeaway for everyone on this phone call in terms of looking at guardian ad litem practice going forward and creating a more trauma-informed practice. I believe we just have 2 more questions that I think I can combine into one, and then we will have gotten everything that's on here. So if anyone has any final questions, start thinking about that. But from some of the folks who were in listen-only mode, there were 2 questions. One was, what about gun violence? And the other was, how does low IQ, for example, 68 to 70, come into the overall picture? So I think those are general questions about the relationship between trauma and gun violence and trauma and low IQ.
Well, let's start with the low IQ. Low IQ comes into the picture in terms of, when we're talking about impact of trauma, the only thing that's significant is that there are some interventions that would not be appropriate for an individual with low IQ. So, for example, trauma-focused cognitive behavioral therapy, there is a lot of linking thoughts and feelings to behavior, and that may be more advanced than an individual with a lower IQ can successfully accomplish. So the interventions will have to be altered. They're different for individuals with low IQ. In terms of what are we looking for symptoms of trauma reaction, you're just going back to premorbid functioning. Was there a change? Sleep, appetite, emotional reaction. Doesn't matter what the IQ is there a change? So the most important piece is the intervention piece. When you're talking about gun violence or community violence is a trauma. And our youth are exposed to extensive community violence. And processing it with our youth is significant, and making sure that they're experiencing a trauma reaction. One thing I think that's going to be very interesting in the coming years, for example, is the code reds that we're doing in our schools now. I know that I'm trying to get together a research team so that we can look at what is the impact of that code red on our children, especially our young children, our 4, 5, and 6-year-olds that are going through these code red drills. We don't know what the impact is right now. So yes, gun violence is considered a trauma, and the community violence is a trauma. It's significant, and it's definitely something that when you're doing a trauma assessment or when you're processing youth, you want to see what their level of exposure to gun violence and community violence is.
Thank you, Dr. McGrath, for entertaining all of our questions and for this incredible presentation. I feel like we've hit so many of the objectives in terms of getting everyone on our group sort of a baseline understanding of the initial science and how it's come along, and in addition to that, how we see it in our own work, and then adjustments that we can make at least preliminarily as we go forward trying to develop policy and recommendations. So I want to say thank you to you. Thank you to everyone for calling in. And again, anyone who has additional questions, please feel free to send them to me and I will see if I can get them answered for you. But otherwise, please look forward to seeing this presentation put on the Guardian Ad Litem website. And as Dr. Mcgrath referenced, our next session will be concerning the developmental ages of children and the specific effects of trauma at different ages. So thank you again, Dr. Mcgrath.
Thank you.